Hello, my name's Dr. Alan Kerry and I'd like to welcome you to another podcast from the South Essex GP Training website. With me I have Dr. Sunil Gupta and we're going to discuss consultation models in general practice. Sunil, can you say a few words about the consultation in general practice?
The consultation is the central task of general practice. Consultation skills form the basis of good patient care. Consultation skills can be learnt by systematic training, and various models have been used to describe what happens in a consultation.
Okay, so the first three consultation models I'd like you to discuss are the Royal College of General Practitioners model of 1972, Byrne and Long's model from 1976, and Stott and Davies consultation model of 1979.
The Royal College of General Practitioners consultation model in 1972 was the physical, psychological and social. The model encouraged the doctor to extend his or her thinking practice beyond the purely organic approach to patients, and it includes the patient's emotional, family, social and environmental circumstances. Byrne and Long in 1976 identified 6 phases that form a logical structure to the consultation. The model was a description of events occurring in a consultation. The 6 phases were: 1. The doctor establishes a relationship with the patient. 2. The doctor either attempts to discover or actually discovers the reason for the patient's attendance. 3. The doctor conducts a verbal or physical examination or both. 4. The doctor or the doctor and patient together, or the patient in that order of probability, considers the condition. 5. The doctor and occasionally the patient details treatment or further investigation. And 6. The consultation is terminated, usually by the doctor. In 1979, Stott and Davies expanded the consultation model to include preventative care, so they described 4 areas which could be systematically explored each time a patient consults. 1. Management of presenting problems. 2. Management of continuing problems. 3. Modification of help-seeking behaviour. 4. Opportunistic health promotion.
Thank you. Can you tell us about Pendleton's consultation model from 1984?
Pendleton's model lists 7 tasks that form an effective consultation. The model emphasises the importance of the patient's view and understanding of the problem. So the first task was to define the reasons for the patient's attendance, including the nature and history of the problem, their cause, the patient's ideas, concerns and expectations, the effects of the problem. The second task is to consider other problems, continuing problems, at-risk factors. Third task is to choose with the patient an appropriate action for each problem. 4. To achieve a shared understanding of the problems with the patient. 5. To involve the patient in the management plan and to encourage him or her to accept appropriate responsibility. 6. To use time and resources appropriately. 7. To establish or maintain a relationship with the patient that helps to achieve the other tasks.
And what were the parts of Neighbour's 1987 model?
The 5 parts of Neighbour's model were connecting, summarising, handing over, safety netting and housekeeping. Connecting is, have we got a rapport? Summarising is, can I demonstrate to the patient I've understood why she or he has come? Handing over is, has the patient accepted the management plan we agreed? Safety netting is, have I anticipated all likely outcomes? And housekeeping is, am I in good enough shape for the next patient?
Other people have had interesting things to say about the consultation as well. What's Hellman's Folk model?
Hellman's Folk model in 1981 said a patient with a problem comes to a doctor seeking answers to 6 questions. What has happened? Why has it happened? Why to me? Why now? What would happen if nothing was done about it? What should I do about it, or whom should I consult for further help?
And what did Heron say were the 6 categories of intervention in a consultation?
Heron in 1975 said there were 6 categories of intervention: prescriptive, informative, confronting, cathartic, catalytic and supportive. Prescriptive is instructions or advice, i.e. directive. Informative is explaining and giving information. Confronting is giving feedback to the patient on their behaviour or attitude in order to help them see what is happening. Cathartic is helping the patient to release their emotions. Catalytic is encouraging the patient to explore his or her own feelings and reasons for behaviour. And supportive is encouraging the patient's self-worth, e.g. by giving approval.
Thank you. I'd now like you to tell us about some of the insights into the consultation that Byrne generated.
He explored the importance and identification of psychological problems. He identified many patients' illnesses are distress that do not fit into an illness pigeonhole and suggested the following very useful concepts. First concept was the doctor as the drug, where the pharmacology of the doctors as a treatment. Another concept is the child as the presenting complaint. The patient may offer another person as the problem when there are underlying psychosocial problems. His third concept was elimination by appropriate physical examination. This may reinforce the patient's belief that his or her symptoms, which are neurotic in origin, are in fact due to physical illness. Repeated investigations perpetuate this cycle. Another concept was collusion of anonymity. Referral reinforces the mistaken belief in the origin of symptoms. The responsibility of uncovering underlying psychosocial problems becomes increasingly diluted by repeated referral, with nobody taking final responsibility. Another concept was the mutual investment company. This is formed and managed by the doctor and the patient. Clinical illnesses are episodes in a long relationship and represent offers of problems, physical and psychological, to the doctor. And the other concept which is of interest is the flash, which is the point in the consultation when the real reason for the offer, i.e. underlying psychosocial and neurotic illness, is suddenly apparent to both doctor and patient. This forms a fulcrum for change. The consultation can now deal with the underlying basic problem.
What's transactional analysis?
Transactional analysis is a concept derived by Byrne in 1964. It explores our behaviour within relationships. It identifies 3 ego states: parent, adult and child, any one of which an individual could be experiencing at any time. It looks at the implications and reasons for different states. It also explores the games people play, which can be used to identify why transactions repeatedly go wrong. This model is useful for exploring consultations by looking at the relationship between the doctor and the patient.
And the final consultation model we're going to discuss is the Calgary-Cambridge model. Could you briefly outline that for us?
Number 1, initiating the session, which is establishing initial rapport, identify the reason or reasons for the patient's attendance. 2, gathering information, which is exploration of problems, understanding the patient's perspective, providing structure to the consultation. Number 3, building the relationship, developing rapport involving the patient. Number 4, explanation and planning, providing the correct amount and type of information, aiding accurate recall and understanding, achieving a shared understanding, incorporating the patient's perspective, planning, shared decision making, and number 5, closing the session.
Thank you. So we'll close the session. Sunil and I would encourage you to read up more about these consultation models. This has just been a very quick overview, but nevertheless we hope you found this podcast helpful, and we'll listen to some of the other podcasts from the South Essex GP Training.